when you say radiation, microwave ovens, electrical
Right.
overhead
Right.
transmissions, things like that?
Those also were looked into great detail, because all the radiation, when I say radiation, those are the radiation where people get radiation, high dose of radiation, like a radiation treatment. If people used to get radiation for their lymphoma to their neck, and they have a cancer from the lymphoma, the radiation that they received. And if somebody had a radiation to the part of the face, then those people get exposure to the radiation to the brain, and those people can get high grade brain tumor. So the radiation means
Concentrated levels.
concentrated high level of radiation. Microwave oven radiations, radiation that passes through the high voltage wiring, those radiation is not enough to cause DNA damage, causes the brain tumor.
Okay.
So far there is no clear evidence of anything like that at this
Some
time.
relief, to hear a doctor say that. Okay. What then should people watch out for specifically for brain tumors? What are the warning signs? How does one end up going to a doctor and discovering they have a brain tumor?
I think that is also a very difficult question, of course, from the symptom standpoint, because it's all depend on where is the tumor is in the brain. Somebody have a large brain tumor and walking with completely no symptoms, versus somebody is having a small tumor but having a major symptoms. So the symptoms depend on the location of the tumor and the size of the tumor, but commonly people have headaches, people have convulsions, they pass out, they have seizures, they feel weak on one side or other side, they feel numb, they have difficulty with the balance, they feel their memory is getting worse, their cognition is getting affected, they loses their mind, in so-called layman's word. So those are the common symptoms people come to the to see the regular doctors.
So memory loss could also be confused if you're an older person with Alzheimer's or dementia or something like that, right?
Right.
Now we got a model of the brain right here, which is you've pulled it in from your office just to show us. But if I were to look at this as a lay person, if a tumor were to hit which part, which is the most likely one to cause visible symptoms?
Well,
if we look at this model right over here.
So looking at this part, this is the brain that we're looking at from the side. This is the front part of the brain, this is the back of the brain, this is the frontal lobe here. And if you have a tumor in this part of the brain, people have difficulties with thinking. Their ability to react to the normal reactions get affected. If somebody had a tumor in this part of the brain, which is called motor cortex, you feel paralyzed on one side or weakness on one side or other side, depending on the location. This is a sensory cortex where people, if the tumor is located here, one can be having sensory numbness on one side or other side. This part of the brain is called occipital lobe. If somebody had a tumor in back of the head here, you lose the vision. You stop seeing one part of the vision in both eyes, and back of the brain here, which is called cerebellum, and if you have a tumor in cerebellum, you start having balance problem and you loses the balance.
So you can actually target then, just by looking at some of the symptoms a patient is displaying, you can target what specifically is happening.
You can guess the possible localization of etiology in the brain, where could be the problem, you will find it.
All right, then let's talk about the treatments now. What happens if you've discovered, say, a particular type of tumor? When does treatment begin? How do you determine it? How long is treatment? And is there such a thing as a cure in a situation like this?
I think that is also a very broad question, and I think we would probably have to divide them into a couple of portions. Brain tumor, as I said earlier, we divide them for the treatment part into the low grade and a higher grade tumor. Low grade tumors, we treat them by the surgery alone, and we don't have to do any other interventions, especially meningiomas, versus other gliomas where treatment depends on a type of the tumor, because not all brain tumors treatments the same. So we design and tailored every brain tumor treatment depending on pathology of the brain tumor. So the most important part, I always tell patients that we want to know what type of brain tumor you have, and for that we need to have a tissue sample. So most time either surgeon can go in and remove the most part of the tumor, and send it to the pathology, and pathologist will tell us this is a type of pathological type of the tumor, and based on that we decide what are we going to do next. So most and again for the gliomas, we do not stage them like most other cancers in the body. We grade them. So grade 1 and 2, what we call low grade brain tumor, where surgery alone could be sufficient, and then we follow them without further treatment, versus grade 3 and grade 4. Grade 3, what we call anaplastic astrocytoma, where after initial surgery or biopsy we treat them, and also glioblastoma multiforme, which is the most malignant brain tumor, and those also need more aggressive interventions. So once patient get their initial surgery, then they come to see me as a neuro-oncologist, and then I take over the care from then onwards. Then I help them start with the radiation, and with the newer information for last 4 or 5 years, we also treat them with the chemotherapy while they were getting the radiation. So we attack concomitantly with combination treatment from the very, very beginning aggressively.
Now you have a special treatment regimen yourself, and I believe this is being now emulated by medical centers around the country.
Right.
And tell us a bit about that. What are you doing different that is now gaining the interest of your peers in the business?
Right. So what that treatment is, what generally happen is once people continue their initial treatment with the radiation and temozolomide, and we monitor them, and once we see any signs of progression, we have to stop that chemotherapy since patient progressed on their chemo regimen. At that point we decide to start them on investigational chemo regimen, and at this time there is no FDA approved systemic chemotherapy. So we used to say, my teacher used to say, pick your poison, because all the chemotherapies are based on the treating oncologist. So we used to pick whatever chemotherapy we decide, and since August of 2005 I started using one chemo regimen, one chemo combination regimen, where I was using irinotecan and bevacizumab, which is what pharmaceutical name is Avastin, for recurrent brain tumor. And since I started using that chemo regimen and later on published that regimen to the several national and international meetings, now this chemo regimen is now published and shown most responsive, most successful chemotherapy
Treating
for treating the recurrent glioblastoma.
So what is a recurring tumor? It's one that's been treated, that's sort of shrunk,
Right.
maybe even down to a 0, and all of a sudden
They come back.
comes back.
Right. And that is a bad part about glioblastoma. With the patient with the brain tumor, all know that there is a potential of this tumor coming back. So that's where we have to keep doing MRIs, that's where we have to keep doing chemotherapy. Even if somebody is so-called in remission, there's no tumor recurrence, even though we still continue the chemotherapy.
Just to sort of kill it all
Killing
together
it all
and make
together.
sure that
Right, because
that poison.
this tumor has microscopic spread inside the normal brain. So surgeon, when they remove, they can remove 100%.